Welcome back to another episode of the Diabetes Digital Podcast. Today, we have an episode for you. So we are interviewing two people. They are the co-host of the SHEMD podcast, and we were actually on their podcast earlier this year. So definitely check that out. Our guests today are Dr. Thais Aliabadi, also known as Dr. A, and Mary Alice Haney. And Dr. A, if you have not heard of her before, is a world-renowned OBGYN based at Cedars-Sinai. She is known for caring for royal families and celebrities. She's appeared on the Kardashians. I have seen every single episode of Kardashians, and I have seen her on there. She's also appeared on The Doctors, Dr. Phil. She has a huge platform and is one of the leading voices for women's health and a strong advocate for women being heard and taken seriously in medical spaces. And also, along with Dr. A, is her co-founder of SHEMD, Dr. Mary Alice Haney, who is a fashion designer, TV host, and women's health advocate.
And it's always so much fun having doctors on our podcast because, as you all know, when you go into the doctor's office, it's very rush. You barely get a word in because you're in and you're out within 10 minutes. So I love this episode because we were able to ask a lot of pressing questions that we had on our minds, but we just never have the opportunity to really sit down with a doctor and talk through these things. So in this episode, we talk about PCOS. It seems like more and more women are getting diagnosed with PCOS. So we talk a little bit about that. How common is it really? How do you diagnose PCOS? What are some risk factors? We also talk about GLP-1s, which, as you all know, we talked about on the podcast, they have become so much more popular. And Dr. A has actually been working with GLP-1s for a very long time. So she had some interesting insights about that. We talk about insulin resistance and fertility as they relate to PCOS and a lot more.
Yeah, and definitely stay until the end because she gives a lot of amazing tips on breast cancer too, specifically, and how to know your risk. She talks about some of her patients who got breast cancer younger and why she would recommend screening early for certain people. I thought it was just amazing. And the breast cancer test that she recommends people take is one that I've also heard other people say that test specifically saved their life, knowing their risk and then knowing that, oops, I need to actually start getting mammograms earlier. So stay to listen till that. And I also feel like we have a very nuanced conversation on all these things. Of course, GLP-1s are a hot topic and we talk about the symptoms. Is it just malnourishment via starvation, or is it something that is really helping people hormonally and metabolically, as well as longevity on those meds? What she has seen in her practice, if people stop taking the GLP-1s and they were taking them for weight loss, do they gain the weight back? We also talk about our thoughts on the body image of it all, the intuitive eating of it all. And Mary had interesting insight that I had not heard before that kind of opened up my mind a little bit on this topic. Now, I do want to say that if you are someone who does not want to hear about weight loss, then this may not be the episode for you because these are things that we talk about in this episode. So just want to let you know, take care when listening. But if you are someone who this is interesting and you want to have some of those nuanced conversations and hear about a doctor in the field who is using these meds, this is definitely going to be an interesting episode for you.
Welcome to the Diabetes Digital Podcast. I'm Wendy.
And I'm Jess, and we're best friends, registered dietitians, and diabetes educators.
Through our telehealth platform, diabetesdigital.co, we offer accessible and personalized virtual nutrition counseling for people with diabetes and prediabetes.
Visit diabetesdigital.co, that's C-O, to book your first appointment. We accept insurance and offer affordable self-pay options. Now, let's get into today's episode.
Welcome to the podcast. We're so excited to have you.
Thank you for having us. We're excited to be here. We're so excited because we had y'all on our podcast and now we get to come on yours. So this is gonna be great.
Pod swap.
Pod swap.
We are so excited to talk about PCOS because I know it's something that you're both really passionate about, and a lot of our patients come to us with PCOS. And I'm not sure if it's social media or I feel like I'm just seeing more and more information out there about PCOS.
It's us.
I'm like, does everyone have PCOS? What's going on? Because I feel like even amongst my friend circles, a lot more of my friends are like, oh, I got diagnosed with PCOS. So what do you think is happening where it seems like more people are being diagnosed? How common is it really? Who is most at risk?
So that's a very good question. PCOS in general affects 15% of women in this country. If you go to Middle Eastern countries, that number can go north of 20%. So it's extremely common, and that's why you're starting to hear more and more about it. The issue with PCOS is 75% of these women are never diagnosed. And if they're diagnosed, they're not being treated correctly. But with these podcasts, with social media, with Chat GPT, more and more people are either self-diagnosing or bouncing from doctor to doctor, demanding for someone to basically diagnose them. So there's more awareness of it. We have so many amazing influencers now that talk about PCOS, that share their journeys, celebrities who've come on our podcast, on different podcasts. They talk about PCOS and mostly the symptoms of PCOS. The problem with PCOS is there's not a single test for diagnosing it. So you can't go to your doctor, do a blood test and say, oh, I have PCOS. And different PCOS patients present differently. So, and the symptoms vary so much that it makes it confusing for doctors to diagnose it, for patients to connect all those symptoms. And we honestly don't get enough experience with it, even in our residency program. So that's part of the issue, educating doctors and educating women about it.
Yeah. One thing that I have noticed too, and I think this is part of just more people getting diagnosed, and I think at first was seeing this a lot on your podcast because you guys do have a lot of celebrities, well-known guests, and I'm seeing these guests who are in smaller bodies, right? Or what I would consider smaller bodies, like Lori Harvey, for example, who open up about their PCOS journeys. And I feel like in the media, historically, PCOS has been linked to people in larger bodies, right? And it's always like, oh, I have PCOS. And, it's struggle with weight and body image and things like that, which I know body image can affect people in all bodies, right? But is that perception accurate with PCOS? I'm very curious on your guys' take.
It's a very good point. So 75% of PCOS patients gain weight. And they're the typical PCOS patients that most of us think of, right? Patients might have acne, facial hair, body hair thinning, irregular period. But 25% of PCOS patients are lean PCOS patients. What does that mean? They're actually they could be underweight, but they have all these other symptoms of PCOS. That's why it's so important to know the criteria for diagnosing PCOS, because weight is not one of them.
Yeah.
So when it comes to diagnosing PCOS, you need to meet 2 out of the 3 criteria. 1 is history of irregular cycles. 2 is PCOS looking ovaries on ultrasound. Polycystic ovary syndrome is not cyst on the ovary, which a lot of doctors look at the ovaries and say, oh, you don't have any cysts, so you don't have polycystic ovary syndrome. It's not true. PCOS is a bad name. Basically, we look for follicles. It's a certain look of these ovaries full of these follicles, not cysts. And it's very specific to PCOS. So that's criteria number 2. And criteria number 3 is symptoms of high testosterone or high testosterone in the blood. You do not need to have a high testosterone in the blood to get the diagnosis of PCOS. So you need to have symptoms of high testosterone. Facial hair, body hair being the most common. Facial acne, body acne, hair thinning, hyperpigmentation under the arm, skin tags. So these are symptoms you look for, symptoms of high testosterone, and you need to meet 2 out of the 3 criteria. So weight is not part of this criteria. So that's why it's so important to learn the criteria for diagnosis. For teenagers, we do not use the second criteria, which is the PCOS looking ovaries on ultrasound, because a lot of teenagers have a lot of follicles, and that can throw off the diagnosis. So for teenagers, you need to meet the first and third criteria. But generally speaking, PCOS patients have mood disorders. They have anxiety, depression, body image issues. A lot of them have family history of diabetes, PCOS, insulin resistance. PCOS patients are at a higher risk of having eating disorders. We see more of the binge eating in this group of patients. And it's one of the leading causes of infertility. One, because the ovulation is not optimum, and some of them don't ovulate regularly, so they have a harder time getting pregnant. But they have all these follicles in their ovaries, but the quality is not optimum. And that's why they sometimes get the wrong message when they go to their gynecologist at age 35, and someone does an ultrasound and says, "Oh, don't worry about it. You have so many eggs." Well, you should worry about it. If you have that many eggs, their quality is probably not as good. So these are patients I usually recommend freezing their eggs earlier on, even though they have tons of follicles.
And we started the podcast about a little over a year now, and it was with the sole intent to make every woman their own health advocate, to give them, I mean, you guys came on and gave the most amazing information. I love that podcast. But women can watch SHEMD, and whether it's a celebrity talking about their own health journey and an amazing doctor like Dr. A or another expert comes on, so that they can be armed with the knowledge and tools to be their own health advocate. And we talk about everything. But what happened at the beginning of this, Thais and I were starting the podcast, and she said, PCOS is my passion. I have two passions. One is to have every woman know her lifetime risk of breast cancer, and we're going to talk about that in a minute. And two is polycystic ovarian syndrome. And I was like, what is PCOS? I've never heard of PCOS. I felt as if I'm very educated in the women's health space. And she explained to me that 75% of women don't know that they have it, and that there were actually supplements that you could take that will work on the symptoms of PCOS. So that will get your ovulation going, that will make your insulin resistant, more insulin sensitive, that will help with all of these symptoms that we just talked about. And she has a list of questions that she gives every single patient that comes into her office for PCOS. So we built OV, our company. We built them at this, launched two companies at the same time, which is always not a really good idea. But so women can go on OV.com, OVII.com, and take the exact questions for free that she gives every patient that walks into her office. And then we can't diagnose you, but we can say you have the likelihood, you don't have the likelihood. Now, and then we can give you the solution, which is OV. It's a once a day, you drink it.
I created this calculator that helps women find out whether or not they have the likelihood of having PCOS. The problem with PCOS is you can go to your doctor, even when you know you have it, there's a 25% chance that you leave your doctor's office and get the correct diagnosis. So it's good to have a place for women to go answer a few questions, and we can tell them whether they have the likelihood of having PCOS. The problem right now with PCOS is still patients go to their gynecologist, primary care doctors, family practitioners, and even when they get diagnosed, the solution is what? They give them birth control pill. Where actually birth control is not always, it might be a great solution for some patients with PCOS, but because of their mood disorder and anxiety and depression, sometimes they don't do well with birth control pills. So sometimes they get prescribed birth control, they go home, they don't do well, they stop it, and then they think that's the solution.
Yeah.
So PCOS is actually one of the conditions that has a lot of underlying pillars that drive the symptoms of PCOS. It could be stress related. It could be inflammation related. It could be insulin resistance. Genetic plays a role in it. Sleep and activity plays a role in it. The food we eat plays a role in it. Gut dysbiosis is an issue. So you have to address all of these underlying pillars for patients to actually start feeling better. That's why so many patients are so frustrated, because they get thrown this birth control pill, and it might help with their acne and hair loss and facial hair and body hair, but it does not really address all these other symptoms that they're experiencing. And that's why, with this, PCOS is one of those conditions where supplements actually make a difference. And, but you have to hit all these underlying pillars with the supplements. And that's what OV does. I used to give so many supplements to so many of my patients. I would literally give them 7 to 8 supplements. So when I met Mary Alice, I said, it's so easy to make one supplement where patients can take it once a day, and it'll address all these underlying conditions, not just their insulin resistance, not just masking their symptoms of PCOS, not just dealing with the inflammation, not just dealing with their gut dysbiosis. So you have to address all of these, and that's how they start feeling better.
Yeah, I mean, and with the birth control, that's something that I personally experienced. And I think a lot of women experience that when they're experiencing abnormal periods, whether it's like endometriosis or PCOS, and it's like they throw birth control on and it's really masking like what might actually be going on. And I'm wondering, because you mentioned insulin sensitivity. We see a lot of people that have prediabetes, diabetes, and PCOS. Would you recommend like a certain kind of specialist? Like, would it be an endocrinologist? Or like for someone that has PCOS, especially if they do have some kind of insulin resistance, what kind of medical specialist would you recommend? Because usually a PCP, you might have to go through like several PCPs to finally get a diagnosis, or, they're not really validating the information that you're giving them.
The sad part is PCOS should be treated by gynecologists, right? It should be treated by family practice, by primary care doctors. Everyone should be able to diagnose it. I mean, I just gave you the criteria. Anyone sitting at home can diagnose themselves right now. But because these doctors don't do it, my personal experience has been, at least in Los Angeles, that endocrinologists are a bit more versed in PCOS, and you're more likely not to be dismissed by your endocrinologist when it comes to PCOS than you are by your gynecologist or maybe other doctors. So I would say start with your gynecologist. Maybe Google, if you think you have polycystic ovary syndrome, Google some, near you, a PCOS specialist. And if you can't find that PCOS specialist, you can start with your gynecologist or or an endocrinologist, right? The problem is, unless the physician is familiar with PCOS, the symptoms of it will get dismissed, right? Yeah. So as I was describing it, PCOS has multiple underlying drivers of the symptoms. The main one is insulin resistance, right? So these are patients who, when they eat carbohydrates, their body does not process the sugar the way others do. And insulin resistance means at a cellular level, their body is resistant to the insulin. The job of insulin is it opens up the receptors on the surface of our cells so they can grab the sugar, put it into the cell, and turn it into energy. This is what's supposed to happen. But a lot of PCOS patients have insulin resistance. So when they have, let's say their body breaks their carbohydrate into glucose, glucose stimulates their pancreas to release insulin, but their cells don't respond to this insulin. So not all of the sugar goes into the cell to turn into energy. It bounces in the blood and pushes their insulin to go up. And that's why eventually, as we get older, you start seeing their hemoglobin A1C, which basically tells us what the blood sugar has been doing over the past 3 months. It starts bumping higher and higher and higher. And eventually, these patients are at risk of becoming pre-diabetic or diabetic if you don't address their underlying condition. But high insulin also stimulates their ovaries to secrete testosterone or androgens. And it is because of that their periods become irregular. They get acne, facial hair, body hair, and different symptoms of high testosterone. So in this pillar, addressing insulin resistance is very important. You can help patients at a cellular, that's why we always start with diet, right? Exercise is very important. When we exercise, we open up these receptors on the surface of our cells. Walking after each meal is very important. For patients who are insulin resistant, who are PCOS, I always say go walk 10, 15 minutes after each meal, and you can significantly reduce the amount of sugar in your blood, which makes a huge difference. A lot of PCOS patients, we give them metformin. Why do we give metformin? Because metformin makes us more insulin sensitive. So by making us insulin sensitive, our body starts responding better to the insulin. So this is just one pillar of PCOS, which is insulin resistance. PCOS patients, generally speaking, tend to have more chronic inflammation. Yeah. And that inflammation drives their ovaries to secrete testosterone and cause all these irregular symptoms, irregular periods, and high testosterone symptoms. So lowering that inflammation is very important. The next pillar is gut dysbiosis. PCOS patients have food sensitivities, and they complain of 40%, half of them almost, complain of bloating with certain foods. And it's important that their gut microbiome is balanced. Genetics play a huge role. Family history of diabetes, PCOS, insulin resistance, gestational diabetes. A lot of us have it hidden in our DNA. And epigenetics is also very important. Our lifestyle is very important. What food we eat, how much processed food we're eating, how much are we exercising, are we sleeping well, what's our stress level? So, and then there's this other main pillar, which is the brain ovary axis, I call it, which basically the hormones in the brain are not secreting in a normal pattern, and it affects our ovulation. So all these pillars work together, and that's why so many PCOS patients present differently.
So it's so hard to diagnose.
That's why it's so hard to diagnose. And that's why throwing a birth control pill at them is not the solution. PCOS patients, last thing I want to say is PCOS patients also tend to have lower sex hormone binding globulin. It's this protein in the blood that grabs the free testosterone in the blood. And by taking birth control pills, we stimulate this sex hormone binding globulin, which starts grabbing the free testosterone in the blood. And by doing that, what it does, it lowers our free testosterone. And that's why the acne, our acne gets better, hair loss gets better, the periods become more irregular. So birth control pills work really well, but they're working in this by suppressing the symptoms of PCOS, right? And lowering that testosterone. Birth control pills do not address your gut dysbiosis, your insulin resistance, the inflammation, in the body. So, and your, sleep and stress level. And on top of that, because these PCOS patients tend to have a lot of mood disorders, sometimes they don't do well with birth control. So I love birth control pills, but it's important to educate patients why they're taking it. Otherwise, your compliance goes way, way down.
Yeah. You mentioned GLP-1s, which I'm happy you did, because there's more and more people that are using them for a range of different conditions, especially like we work in prediabetes and diabetes. So it's very big in that space. And because you've been using it for such a long time, I wonder what your thoughts are on people like adequately nourishing when on a GLP-1, because something that we see as dietitians is that because of the delayed gastric emptying and the side effects, it's really hard for people to meet their nutritional needs because they just don't have much of an appetite. They are barely getting enough calories in. And so then they're at risk for like different nutrient deficiencies and things like that. So like what are usually like, what would you advise those patients who are struggling with nutrition intake?
I think, first of all, I would adjust their dose. I always say you're not supposed to not eat all day. I think the second problem is a lot of these patients are getting these compounded GLP-1s from websites without their doctor's knowledge, right? Yeah. But it's so important for patients to feel comfortable to let their doctors know, because it's good to work with a nutritionist. I think that's critical for these patients to have a nutrition, and you need to make sure that your electrolytes are fine, that you're drinking enough. And that's why it's so important to have an experienced healthcare provider follow these patients.
Yeah, it's very unfortunate too, because yes, we do have a lot of patients on GLP-1s as well. And I think people are stuck between a rock and a hard place because the drugs can be so expensive, especially if somebody is using it outside of diabetes, right? So let's say someone with PCOS or somebody who is trying to lose weight, it's like $1,000, maybe $500 a month.
It shouldn't be $1,000. It shouldn't be $1,000. But you're right. It is even like $500 a month.
That's a lot.
That's a lot of money. Yes, 100%.
And it should be covered, honestly, for all these patients with PCOS, pre-diabetic, diabetic patients. It really should be covered.
Yeah, and that's like, to the point of, even if it is $500, because I know they have the coupons or whatever, that's still for the average person, right? That's so much money a month. And so just from that point of view, I can see it creates a dangerous situation, right? Because then people are like, oh, I need this, for whatever reason. And now I'm going to go on these compounding websites and get a version that has maybe fillers or who knows what it is, that's not the studied version. And so I think that can be tricky. And then also, I think one of the other tricky things, like you're saying, is many providers don't know that their patients are even on it because it's not their primary care provider or their OBGYN or their endocrinologist who is following up with them regularly and knows their history and maybe has seen them in person before. And sometimes even if it is your provider, like one of my friends is a nurse in an endocrinology clinic, and they can't see that they're so impacted that they can't even see the patients like more than once every few months. And as we know with these medications, it's tricky because big changes can happen, symptoms can happen like very quickly. And so that is where I think a dietitian does come into play, is like we're able to see them weekly and make sure that they are trying to strategize ways to still eat, get the protein like you're saying. But yeah, we ask our dietitians all the time and they say that a lot of their patients on GLP-1s can't even, it's hard for them to even hit 2 meals a day. And so trying to really strategize with them, okay, well, then how are we going to figure out your protein?
And you say that that's too much. Then they're just,
I drop their dose. Yeah. Remember, I always tell them you want to be able to stay on it long term. I always do a check-in, always at 4 months. But it's important for them to know eating is, you can't not eat. And one of the side effects of these medications is fatigue. I'm sure you guys have heard about that. Patients sometimes feel exhausted. I drop the dose for that. I drop the dose if they're nauseous. I drop the dose if they're very constipated. I drop the dose if they're not eating. I drop the dose if they're losing too much weight too fast. So it's so good to be monitored by someone who's, you can't just do this on your own at home. But I'm telling you, a lot of women are doing this.
I know. And it's like just so interesting because it's so in the news, and I'm happy we're bringing this conversation up and that you have the experience. Because another thing is, if you are with the compounded companies, they have an interest in you increasing the dose, because the more you increase and stay on it, then they're going to get paid. So it's like, I don't know. It's just interesting bringing in tech companies and for-profit with like healthcare. It's tricky.
I always encourage my patients to use not the compounded medications, but the medications that are FDA approved. And I always say you don't know where the raw materials are coming from in these compounded medications. So be safe and use the FDA approved medications unless there's a shortage.
This is a fascinating conversation. We're just going to ask you like a couple more questions just to respect your time. But one question I have, and I know, Mary, when we were on your pod, we talked about, I think, like body image. And I know like you're very familiar with intuitive eating and all those things. Like, how do we reconcile this new drug, right? And that can have that weight loss result for people, when I feel like we're just getting to a place where we were, like just as a culture, like encouraging people to accept their bodies as they were. So I feel like it's a personal choice, obviously. And I think there's a lot coming out about these medications that can be very helpful. There's also the side effects and other things that, we're still studying. But yeah, I would love your guys' thoughts on how do we reconcile that, like the body image of it all, the intuitive eating of it all with these medications?
I think it's not one and the same, in my opinion. Like these amazing medicines, GLP-1s, metformin, these are over here and they're very specific. So they're helping you, they're either treating a disease or they're helping inflammation, whatever it is, they're over here. You can still need to work on that over here, which is your body image and your self-worth and on all the things that we talk about, and eating correctly, like working with people like you guys, because they feed each other. And I think that and I always ask Thais this question. I say this, all these studies come out about GLP-1s, which is, it's amazing. And I'm like, well, is that because of the GLP-1s, the ingredient?
Like a mechanism.
I don't think we quite know the answer to that yet. I think there's a lot more research that needs to happen. But I think that, when I first met Dr. A and if you listen to beautiful podcast that we did with Phoebe Hancock and her mom started Beauty Counter, and just the trials and tribulations that she went through. And you look at this young woman who just dealt with, hospitalized for eating disorders, all of these things that young girls deal with. But then you put on a PCOS, all the symptoms that come with PCOS. And then it's just they can work together, and they should work together. And if you have a patient or a child who's suffering from an eating disorder or self-image and body image, you have to, I hate to say holistic, we talk about that so much, but you have to really hit it from all angles. You have to hit it from her mental health. How in the world is she supposed to feel amazing and empowered and good within her body, because her body's not working correctly? And that's why when we met and started the podcast, and she said, I want to change the world for PCOS. And there are solutions. There are things that you can do that will help them and support them. So I think it's really a conversation. We live in LA, this body dysmorphia, body image factory that we have is something that we combat all the time. But that's very different than having somebody whose body's not working correctly and feeling terrible. And no matter what you do, some of these people are, so I think that's why it became such a passion for both of us, because we, sort of seeing both of those things.
And I think we live in a world of social media when everyone's face tuning and changing their bodies. And here you have these teenage girls, and it's really hard to be them. And for them to go to a pediatrician, get dismissed. And you remember this, majority of these patients are not diagnosed with PCOS. And what they hear at their pediatrician's office is, well, honey, eat less.
Yeah.
And you need to start exercising more. And this gaslighting needs to end. We need to start diagnosing these patients. And it's really, really sad. I have a patient, she's in her 20s, and she came a few months ago to my office, and she walked in with such confidence. And when she saw me, she started crying and hugging me. I said, what happened? She's like, I wanted to tell you this, but this is the first time in my life I know what it means to be happy.
Yeah. That's powerful.
I mean, do you know what I'm saying? They feel validated. They feel heard. Their body, like Mary Alice was saying, is starting to function like everybody else's body.
I'm happy because my body's working, and it was not working, and no one would believe me, and there wasn't anything I could do about it. And so that's why it's been our mission to change this. And that's why I love being on podcasts like yours, and the work that you guys are doing is so important and incredible too. But there are some things in life that you cannot change. This is not one of them. And if you're educated, and if you have the right resources, and that's why we wanted to provide, on Ovi, a place where you could go where, sometimes you're not being treated by your doctor correctly. And we love doctors. Doctors are the best. But here's a place that you can go to, to try to figure this out yourself. And then we offer a solution. So,
or even imagine you're 30 years old, your skin is covered with acne. You're losing hair. Every time you go in the shower and you brush your hair, you lose tons of hair, right? You're constantly lasering your facial hair, and it comes back. Eventually, it affects your confidence.
Yeah.
Anyways, my heart is full for these patients. And I just want them to know that there's an hormonal imbalance that's causing all this. And there is a solution. But in order to get to the solution, you need to be diagnosed correctly.
Yeah.
So if you're being dismissed, if you go to your doctor and you feel like you have PCOS and you're not being diagnosed correctly, then either Google the PCOS doctor near me or go on ov.com. I created this calculator. It's free of charge. And, listen to podcasts like yourself. We have many podcasts on SHEMD. Just educate yourself. You can honestly go on ChatGPT right now, punch in your symptoms, and 9 out of 10, probably higher than that, you'll get a very accurate diagnosis. Use the tools that are available to you.
Yeah, that was my last question. You kind of answered it in terms of your resources. So I know that you mentioned you have your site. Now, your site helps people to just see if they might have PCOS or the symptoms, right? Is there also a breast cancer component? We had to mention that at the top, like screening wise?
Yes, let's talk about breast cancer. So we have our breast cancer information on the SHEMD podcast because
Okay.
OV is only for PCOS.
Okay.
That's my baby over there. And SHEMD is just educational. So, I always say, if you know your first name, last name, date of birth, you need to know your lifetime risk of breast cancer as a woman.
Yeah.
And that should be mandatory. And that number should be calculated by age 30. Why? Because an average American has a 12.5% chance of getting breast cancer. 1 out of 8 women gets breast cancer. Less than 5% of breast cancers are genetic. 85% of women who get breast cancer don't have anyone in their family with history of cancer. To this day, women come to my office and they say, I don't need a mammogram because I don't have breast cancer in my family. I didn't have breast cancer in my family. I didn't have any cancers in my family. And I was diagnosed with breast cancer.
Oh, wow.
1 out of 8 is real. But why is it important to know your lifetime risk of breast cancer? For women with family history of breast cancer, for women who've had an abnormal biopsy of their breast that shows atypia, these 2 subgroups of women, their lifetime risk of breast cancer shoots up, right? To sometimes above 20%. 20% and more, you fall into the high risk category for screening. If you have dense breast, 50% of women have dense breast tissue. Some of those patients have extremely dense breast tissue. If you have extremely dense breast tissue, it pushes your lifetime risk of breast cancer up. Then there are little factors that also affect it. Early period, late menopause, fewer children in life, not breastfeeding, being on hormone exposure. So, and that number, you can't sit here and say, I don't have my lifetime risk is low. You really need to punch in that information. The formula I use is the Tyrer-Cuzick formula. We have it on GMD podcast. You have to answer a few questions. You need to know your density of the breast to get a better, more accurate diagnosis. You need to know your family history. The breast density, you get that information from your mammogram or your breast MRI if you've had it. But you want to know your lifetime risk of breast cancer. If that lifetime risk of breast cancer is 20% or more, you have to start your breast imaging as early as 30, not 40. So this idea of that people always talk about and doctors talk about that mammograms should start at 40, it's completely misleading. Mammogram starts depending on your lifetime risk of breast cancer. If that lifetime risk is 20% or more, you might have to start as early as 30. And in addition to mammogram and ultrasound, you might you want to ask your doctor for additional imaging like breast MRI. Mammograms alone diagnose 4 out of 5 breast cancers. So by adding the ultrasound and MRI, you start getting closer to that accuracy of diagnosing cancers early. When it comes to breast cancer, remember it's curable, but you have to diagnose it early.
Yeah.
Even though 5% of breast cancers are genetic, if you have family history of ovarian cancer, breast cancer, pancreatic cancer, or other cancers, you might qualify for genetic testing. And if you qualify, insurance will cover it most of the time. So it's important to do these. Ask your doctor for these genetic testing. A, to make sure you have a genetic mutation. B, have your doctor or have yourself go on SHEMD. And
we have lots of podcasts on it. She saved Olivia Munn's life from breast cancer. So you can just go on SHEMD.
Dr. A, I saw in a magazine or something that you were Rihanna's doctor, and they asked Rihanna what was her favorite thing about living in LA, and she said her gynecologist. So are you seeing new patients? Like, I know you work with the celebs, but I'm sure there's going to be people listening who want to get in on your care. Like, how does that work?
Majority of my patients are not celebrities. For me, when you come into my office and you wear that pink robe, you are my patient, you become my family, and I'll give you the highest level of care that I provide. I love, love, love my patients who, I spend a lot of time with my patients, so I don't take insurance, unfortunately, because with insurance, I didn't have this amount of time. I can't spend the amount of time that I want to spend with them.
Which is why we started the podcast.
That's why we started the SHEMD podcast, because really, if they listen to our podcast, I share everything I do in my office, topic by topic, with these patients on this podcast. So they really don't need to come to my office. And when they do, I love them and I take care of them. But I just want to clarify, I love Rihanna. She's the most incredible, most loving, most down to earth human ever. And but all my patients, I love all.
You love them all. Yeah.
I love women, period.
Well, thank you guys so much and for being generous with your time. We appreciate it. Definitely everyone check out the SHEMD podcast, check out OV. I see it has a inositol, which has been very well studied for PCOS. Yes. So yeah, we're so excited for this episode to come out. Thank you both.
Thank you for having us.
Thank you for having us.
Bye. Thanks for joining us for today's episode. If you're interested in nutrition counseling with one of our expert dietitians to help improve your prediabetes or diabetes, visit us at diabetesdigital.co.
Also, if you found our conversation helpful, do us a favor and rate and review this podcast on iTunes, plus share with someone who might find this helpful. You can also connect with us on Instagram at diabetesdigital.co.
And tune in every Wednesday for practical, inclusive, and culturally humble diabetes insights. We'll catch you later. Bye.